Welcome back to the Pharmacology Vault, your go-to space where we simplify complex medical science into clear, engaging concepts. Today, we're unlocking the world of Parkinson's disease, a condition that affects movement, emotions, and even daily life in ways you might not expect. We'll break down what it is, how it develops, the science behind dopamine loss, and the treatments available, all in a way that's easy to follow but scientifically accurate. By the end of this session, you'll not only understand the symptoms, but also the underlying neurobiology that makes Parkinson's so unique and challenging to treat. So, let's get started. Parkinson's disease, or PD, is classified as a chronic, progressive neurodegenerative disorder. Let's unpack what that means. Chronic, it's long-lasting, often spanning decades. Progressive, symptoms worsen over time. Neurodegenerative, it involves the gradual destruction of specific nerve cells in the brain. The main area affected is the substantia nigra pars compacta, a darkly pigmented region in the midbrain responsible for producing dopamine. Dopamine is the neurotransmitter that allows smooth, purposeful movements. Without it, movements become slow, rigid, and difficult to initiate. When we talk about Parkinson's disease, the numbers themselves tell a story. Imagine a room filled with 100 people over the age of 60. Statistically, at least one of them will be living with Parkinson's. For most, the first signs appear after the age of 60, but there's also a less common, early onset form that can strike in middle age or even earlier. And while the disease affects both men and women, studies consistently show it's slightly more common in men, a difference that remains one of the many mysteries still puzzling researchers. When we look at the types, about 90% of cases are idiopathic, meaning no single, clear cause can be found. The remaining 10% are familial, linked to inherited genetic mutations in specific genes, like SNCA, which codes for alpha-synuclein, or LRRK2, which affects cell function. As for risk factors, age stands at the top of the list, the greatest and most consistent predictor. Genetics play a role, but having a mutation doesn't always mean you will develop the disease. Environmental exposures are also important. Certain pesticides, herbicides, and heavy metals have been linked to an increased risk. And then there's head trauma. Repeated injuries to the brain, such as those sustained in contact sports, may raise the likelihood of Parkinson's later in life. In essence, Parkinson's disease is not born from a single cause. It is the outcome of a delicate and dangerous convergence between aging, genetic vulnerability, and environmental insults. Together, they lead to one tragic result: the slow but steady disappearance of dopamine from the brain's control center for movement. Clinically, Parkinson's comes in different forms. The primary or idiopathic type is the classic form, where the cause remains unknown. Secondary Parkinsonism can result from specific medications, like antipsychotics that block dopamine, as well as toxins, brain infections, or vascular damage. Finally, there are the Parkinson plus syndromes, conditions that mimic Parkinson's but bring along additional, often more severe features. These include multiple system atrophy, MSA, which also affects autonomic functions, progressive supranuclear palsy, PSP, which severely impacts eye movement and balance, and corticobasal degeneration, CBD, which causes asymmetrical rigidity and cognitive decline. To truly understand Parkinson's disease, we first need to understand dopamine, the star of our story. Dopamine is not just a feel-good chemical, it's a master regulator, orchestrating movement, emotion, and even hormone control. It all begins with an amino acid called L-tyrosine, which we get from our diet, especially from protein-rich foods. Inside specialized neurons, L-tyrosine is converted into L-dopa by an enzyme known as tyrosine hydroxylase, the rate-limiting step in dopamine production. L-dopa is then transformed into dopamine by another enzyme, dopa decarboxylase. From here, dopamine can be further converted into norepinephrine and eventually epinephrine, forming part of the body's catecholamine family. Dopamine works through four major pathways in the brain. Nigrostriatal pathway. Running from the substantia nigra pars compacta to the striatum, this pathway is the control center for movement. It's the one most devastated in Parkinson's. Mesolimbic pathway. From the ventral tegmental area, VTA, to the limbic system, influencing emotion, reward, and motivation. Mesocortical pathway. from the VTA to the cerebral cortex, shaping cognition, attention, and problem-solving. Tuberoinfundibular pathway, from the hypothalamus to the pituitary gland, where dopamine acts as a brake, preventing excessive release of the hormone prolactin. On a molecular level, dopamine communicates by binding to two main families of receptors. D1-like receptors, D1, D5, excitatory in nature, they increase levels of CAMP inside the cell, promoting neural activity. D2-like receptors, D2, D3, D4, inhibitory, reducing CAMP levels and damping down activity. In a healthy brain, these pathways and receptors are in perfect balance, ensuring smooth movement, stable mood, sharp thinking, and hormonal harmony. But in Parkinson's disease, especially with damage to the nigrostriatal pathway, this harmony collapses, and movement begins to falter. In Parkinson's disease, degeneration of dopaminergic neurons in the substantia nigra impairs the basal ganglia's motor regulation. The direct pathway, D1, which normally facilitates movement through excitatory signals, becomes underactive, making movement initiation difficult. Conversely, the indirect pathway, D2, which normally suppresses unwanted movements via inhibitory signals, becomes overactive, leading to excessive movement inhibition. This imbalance between the two pathways results in the characteristic motor symptoms of Parkinson's disease, such as bradykinesia, rigidity, and reduced spontaneous movements. Parkinson's disease, PD, is characterized by a progressive and selective loss of dopaminergic neurons within the substantia nigra pars compacta, SNPC, a critical region responsible for dopamine synthesis and release in the basal ganglia. This neuronal loss leads to reduced dopamine availability in the nigrostriatal pathway, disrupting motor control. A hallmark pathological change is the abnormal accumulation of the protein alpha-synuclein within neurons, forming intracytoplasmic inclusions known as Lewy bodies. In addition, neuroinflammatory processes, oxidative stress, and mitochondrial dysfunction play key roles in amplifying neuronal injury. Collectively, these mechanisms drive the gradual depletion of dopamine and the emergence of motor and non-motor symptoms. Cellular-level pathogenesis. Lewy bodies, intracytoplasmic aggregates primarily composed of misfolded alpha-synuclein, which interfere with normal neuronal function and trigger cell death pathways. Neuron loss. Degeneration of dopaminergic neurons in the SNPC, leading to decreased dopaminergic signaling in the striatum and impaired motor coordination. Oxidative stress. Excessive production of reactive oxygen species, ROS, damages lipids, proteins, and mitochondrial DNA, impairing cellular energy production and further contributing to neuronal death. Genetic mutations. Mutations in genes such as SNCA, LRRK2, Parkin, and PINK1 disrupt protein folding, mitochondrial quality control, and cellular homeostasis, thereby increasing susceptibility to dopaminergic neuron degeneration. Parkinson's disease manifests through a combination of motor and non-motor symptoms, with the cardinal motor features often summarized using the TRAP mnemonic. These symptoms arise primarily due to dopaminergic neuronal degeneration in the substantia nigra and the resulting impaired basal ganglia function. Motor symptoms are often progressive, starting asymmetrically and worsening over time, leading to significant functional impairment. In addition to the TRAP features, patients may exhibit other motor signs such as a shuffling gait, episodes of freezing during movement, stooped posture, and reduced arm swing, all of which further affect mobility and independence. Tremor. Resting tremor, typically starting in one hand, described as pill rolling movement between thumb and forefinger, occurring at 4 to 6 Hz, often worsening with emotional stress and disappearing during voluntary movement or sleep. Rigidity. Increased muscle tone presenting as cogwheel, rigidity, jerky resistance, or lead pipe. Rigidity, smooth, sustained resistance, during passive limb movement, due to simultaneous contraction of agonist and antagonist muscles. Akinesia, bradykinesia. Bradykinesia refers to slowness in initiating and executing movements, often accompanied by masked facies, reduced facial expressions, soft speech, hypophonia, and reduced spontaneous gesturing. Postural instability. Impaired balance and inability to make quick postural adjustments, leading to a high risk of falls, often assessed by the pull test, where the patient cannot recover balance when pulled backward. Other motor features. shuffling gait with short, hesitant steps, freezing episodes, especially at doorways or turns, stooped, flexed posture, reduced arm swing during walking. Non-motor symptoms in Parkinson's disease often appear years before the onset of classic motor features, making them important early markers for diagnosis. They involve multiple physiological systems and significantly impact quality of life. These symptoms result from degeneration of dopaminergic and non-dopaminergic pathways, affecting autonomic, cognitive, psychiatric, sensory, and sleep-related functions. Autonomic dysfunction of the autonomic nervous system leads to gastrointestinal, cardiovascular, and urinary symptoms. Common examples include chronic constipation due to slowed gut motility, orthostatic hypotension, a sudden drop in blood pressure upon standing, causing dizziness, urinary urgency, frequency, and excessive sweating. Cognitive decline ranges from mild executive dysfunction to Parkinson's disease dementia. Patients may experience difficulties in planning, multitasking, attention span, and working memory. Slowed thought processes, bradyphrenia, are also common. Psychiatric neurochemical imbalances, especially in serotonin and dopamine pathways, contribute to psychiatric manifestations. These include depression, generalized anxiety, apathy, and visual hallucinations, often related to dopaminergic therapy. Sleep disorders are frequent and debilitating. REM sleep behavior disorder, RBD, involves acting out dreams, sometimes violently. Other problems include insomnia, excessive daytime sleepiness, and fragmented sleep patterns. Sensory abnormalities are common early signs. Hyposmia or anosmia, reduced or absent smell, can occur years before diagnosis. Patients may also report diffuse body pain, tingling, or burning sensations. Diagnostic approach in Parkinson's disease. Clinical diagnosis. The diagnosis of Parkinson's disease is primarily clinical, relying on a detailed medical history and thorough neurological examination. Clinicians look for hallmark motor symptoms such as bradykinesia, slowness of movement, combined with at least one additional feature, resting tremor, muscular rigidity, or postural instability. Standard diagnostic criteria. The UK Parkinson's Society Brain Bank criteria are commonly used. According to these guidelines, the presence of bradykinesia along with one or more of the following, resting tremor, rigidity, or postural instability, supports the diagnosis. Supportive diagnostic tools. While the diagnosis remains primarily clinical, certain investigations can provide supporting evidence or help exclude alternative causes. DaTscan, dopamine transporter SPECT, demonstrates reduced dopamine transporter uptake in the striatum, which is characteristic of Parkinson's disease. MRI or CT scan, typically normal in idiopathic Parkinson's disease but useful for ruling out structural or vascular brain lesions that could mimic its symptoms. Differential diagnosis, rule out conditions. Before confirming the diagnosis, it is essential to exclude other causes of Parkinsonism. Drug-induced Parkinsonism, often caused by dopamine-blocking agents such as antipsychotics, e.g., haloperidol, or antiemetics like metoclopramide. Parkinson plus syndromes, conditions such as multiple system atrophy, MSA, and progressive supranuclear palsy, PSP, present with Parkinsonian features but have additional distinguishing characteristics and poorer response to levodopa therapy. The primary objectives in the management of Parkinson's disease revolve around three key aspects. Symptom control. The foremost aim is to effectively reduce both motor symptoms, such as tremor, rigidity, and bradykinesia, and non-motor symptoms, like depression, sleep disturbances, and autonomic dysfunction. This ensures that the patient experiences maximum functional ability in daily life. Delay in motor complications. Over time, long-term treatment, especially with levodopa, can lead to complications such as motor fluctuations, on-off phenomenon, and dyskinesias. The goal is to strategically plan therapy to delay the onset and progression of these complications through appropriate drug selection, dose adjustments, and adjunct therapies. Preservation of quality of life. Beyond physical symptoms, the treatment strategy also focuses on maintaining emotional well-being, social engagement, and independence in daily activities. This includes multidisciplinary care involving physiotherapy, occupational therapy, speech therapy, and psychological support. Levodopa plus carbidopa. Levodopa is the cornerstone of Parkinson's treatment and functions as the direct precursor to dopamine. Since dopamine itself cannot cross the blood-brain barrier, levodopa enters the brain where it is converted into dopamine, replenishing the depleted neurotransmitter. Carbidopa is co-administered to inhibit the enzyme dopa decarboxylase outside the brain, which prevents premature conversion of levodopa in the periphery, thereby increasing the amount that reaches the CNS and reducing peripheral side effects like nausea and cardiovascular symptoms. This combination is the most effective treatment for alleviating the classic motor symptoms such as bradykinesia and rigidity. However, with long-term use, patients often experience motor complications like wearing-off phenomena and dyskinesias. Dopamine agonists, pramipexole, ropinirole. Dopamine agonists directly stimulate dopamine receptors, mainly D2 and D3 subtypes, mimicking the effect of endogenous dopamine without needing conversion in the brain. They are useful as monotherapy in early Parkinson's disease to delay the introduction of levodopa or as adjuncts to reduce motor fluctuations in advanced stages. While they carry a lower risk of motor complications compared to levodopa, dopamine agonists can cause side effects such as impulse control disorders, compulsive behaviors, hallucinations, and excessive daytime sleepiness. MAO-B inhibitors, selegiline, rasagiline. These drugs inhibit the monoamine oxidase B enzyme responsible for breaking down dopamine in the brain, thus prolonging dopamine's action and availability. MAO-B inhibitors offer mild symptomatic relief and can be used early in the disease course to delay levodopa initiation or alongside levodopa to reduce off periods when the medication's effect wanes. However, caution is necessary when combined with other serotonergic drugs to avoid serotonin syndrome. COMT inhibitors, entacapone, tolcapone, catechol O-methyltransferase, COMT inhibitors block the COMT enzyme that metabolizes levodopa in the periphery. By inhibiting this enzyme, these drugs prolong levodopa's half-life and increase its central nervous system availability, improving motor symptom control and reducing wearing-off fluctuations. Entacapone is widely used due to a favorable safety profile, whereas tolcapone, while more potent, requires close liver function monitoring because of potential hepatotoxicity. Both are only effective when combined with levodopa therapy. Anticholinergics, trihexyphenidyl. Anticholinergic drugs work by blocking muscarinic acetylcholine receptors in the basal ganglia, helping restore the imbalance between acetylcholine and dopamine activity that contributes to Parkinsonian tremor. They are particularly useful for managing tremor-predominant symptoms in younger patients. However, due to their side effects such as memory impairment, confusion, dry mouth, and urinary retention, their use is limited, especially in elderly patients. Amantadine, originally developed as an antiviral agent, amantadine exerts multiple actions including antagonism of NMDA glutamate receptors, which helps reduce excitotoxicity. It also promotes dopamine release and inhibits its reuptake. Amantadine is particularly helpful for managing levodopa-induced dyskinesias and can also improve tremor and rigidity to some extent. Side effects may include livedo reticularis, a mottled skin discoloration, and peripheral edema. Advanced therapies and non-pharmacological support in Parkinson's disease. Surgical options, deep brain stimulation, DBS, for patients who develop significant motor fluctuations and dyskinesias that are difficult to control with medication alone. Deep brain stimulation, DBS, offers an effective surgical treatment option. DBS involves the implantation of electrodes in specific brain regions, most commonly the subthalamic nucleus, STN, or the globus pallidus interna, GPI. These electrodes deliver controlled electrical impulses to modulate abnormal brain activity associated with Parkinson's symptoms. DBS can substantially improve motor function, reduce medication requirements, and enhance quality of life. However, it is generally reserved for carefully selected patients who have adequate cognitive function and no significant psychiatric comorbidities. Non-pharmacological strategies. Management of Parkinson's disease extends beyond medications and surgery, with a multidisciplinary approach essential for optimal outcomes. Physiotherapy focuses on improving gait, balance, and mobility, helping reduce the risk of falls and maintain independence. Speech therapy addresses hypophonia, soft speech, and dysarthria, enhancing communication ability and social interaction. Occupational therapy assists patients in adapting their daily activities and environment to compensate for motor limitations, promoting safety and autonomy. Dietary management plays a supportive role, especially the timing of protein-rich meals to optimize levodopa absorption, as high protein intake can interfere with drug uptake. Support groups and psychological counseling provide emotional support, help patients cope with the disease, and address depression or anxiety commonly associated with Parkinson's. Experimental therapies. Ongoing research aims to develop disease-modifying treatments that go beyond symptomatic relief. Stem cell therapy explores replacing lost dopaminergic neurons using pluripotent stem cells to restore dopamine production. Gene therapy targets specific enzymes like aromatic L-amino acid decarboxylase, AADC, or glutamic acid decarboxylase, GAD, to enhance dopamine synthesis or modulate neural circuits. Neuroprotective agents, such as glial cell line-derived neurotrophic factor, GDNF, and coenzyme Q10, CoQ10, are investigated for their potential to slow neuronal degeneration by reducing oxidative stress and promoting cell survival. While promising, these experimental therapies are still under clinical investigation and not yet part of routine clinical care. Let's break down the essentials in a quick, easy-to-understand overview so you get the full picture, from what causes the disease to the latest treatment options and exciting future directions. At its core, Parkinson's is driven by the gradual loss of dopamine-producing neurons in a brain area called the substantia nigra pars compacta, SNPC, the very cells responsible for smooth, controlled movement. Pathology. This neuron loss doesn't happen quietly. It's accompanied by the buildup of toxic protein clumps called Lewy bodies, mainly made of misfolded alpha-synuclein, which further disrupt brain function. Motor symptoms. You might recognize the classic symptoms summarized as tremor, rigidity, akinesia, or bradykinesia, and postural instability. These lead to the characteristic shaking, stiffness, slow movement, and balance problems. Non-motor symptoms. But Parkinson's isn't just about movement. It also affects thinking, mood, sleep, autonomic functions like blood pressure, and even senses such as smell. These symptoms often appear years before the motor ones. Diagnosis. Doctors primarily rely on clinical examination, supported by imaging tools like DAT-scan to see dopamine loss and MRI to exclude other brain diseases. Treatment. We have effective medications like levodopa and dopamine agonists to manage symptoms, along with enzyme inhibitors to boost their effects. Advanced options. For more advanced cases, deep brain stimulation and cutting-edge experimental therapies like stem cell and gene therapy offer new hope. Looking ahead, the future is bright, with ongoing research focused on early detection and disease-modifying treatments that could change the course of Parkinson's, potentially halting its progression altogether. And that's a wrap on our deep dive into Parkinson's disease and how dopamine plays a starring role. What part surprised you the most? Drop your thoughts in the comments. I love hearing what you find interesting or tricky. If this video helped you get a clearer picture of Parkinson's and its treatments, smash that like button and share it with your study buddies or anyone who could benefit. Want more content that breaks down complex pharmacology topics into easy-to-understand bites? Then hit subscribe and ring the notification bell so you never miss an update from the Pharmacology Vault. Got questions or topics you want me to cover next? Write them below. Your ideas could be featured in future videos. Thanks for hanging out and learning with me today. See you in the next one.